Dr. Choll came here from sunny San Diego, California. It is sunny today with a high of 91 in November. So you can see why people that move to San Diego never want to leave, because it's awesome weather. Anyway, we've got a very important patient all the way down from LA. He is a real estate magnate, so we have to do a good job. He knows all my buddies and friends that are spine surgeons as well. And he was sent to me by another spine surgeon. Look at how complicated this case is. He's had a previous fusion of 4-5. He's got a degenerative scoliosis, and the right side is collapsing down. So guess what? The nerves on the right side are being pinched, and he's got pain on the right side of his back and his front of his leg. He's tried everything, including targeted injections, which gave him temporary relief, but not long-term relief. And he's a very young 78-year-old, just like a lot of my patients, including my mom, who's 86. Anyway, he wants to get back to living his life and being busy because he's still actively working. Let's look at the MRI, because that's what really shows what's going on. So here's the side view of his back, and here's the bologna slice axial cut. And I can scroll up and down. See that yellow line moving up and down? That is the L1-2 level, relatively normal. All his levels are really bad, but you can see that there's tons of room in the canal. But when you get down to 2-3, you can see this disc protrusion right there. And you can see it right here on the right side. And remember, he's tilted and collapsed over on that right side. So on top of this bulging out, the space is narrower just because of the tilt. And 3-4, the level immediately above his fusion, also very bad. You can't even see the individual nerve rootlets anymore because everything's so crowded. You can see the screws from the surgery from the level below. They look perfect. But it's this opening right here and here that we're treating on the right side. So if you look on the left side, you can see the nerve surrounded by fat. Same thing here. But on the left side, look how crazy it gets. You can't even see the nerve at 3-4 on the right side. On the left side, this big disc herniation is not crushing the nerve, but it's irritating it. And keep in mind, when you lay down, the tilt is not as bad. So both sides on the right side will get worse as the patient stands up, gravity takes hold, and you end up leaning like this due to the scoliosis. So on top of the disc bulges is the mechanical closing down of that space. So we're going to use the most minimally invasive technique that I have, called the laser endoscopic discectomy surgery, or LESS for laser endoscopic spine surgery. And you have to admit, that is a cool name for a minimally invasive procedure. LESS. Anyway, the idea is to not remove any more bone, because that will destabilize the segment further, while still being able to do all the work that you need. And by using the endoscope, which is basically a 7mm channel, it's like the size of my pen or smaller, I'll go in through the natural opening called the neuroforamen, and I'll remove all this junk right here, using a combination of the laser, the burr, the pituitary rongeurs, mechanical instruments, reamers, whatever it takes, in the famous words of Jack Bauer. I'll do what I have to, while at the same time trying to avoid injuring the most sensitive part of the spine, called the dorsal root ganglion. I love saying that word, dorsal root ganglion. It would be like a really good name for a heavy metal band, but it's also termed the DRG. It is right here where, in his case, the stenosis is, and it's the part of the nerve that looks like a bulb, and that's where all the cell bodies are. And if you just even look at it cross-eyed or touch it wrong, it will start firing, and it is not fun. Patients with that problem have both back pain and leg pain, or a combination thereof, and it is not fun. And that's one of the risks of doing the surgery. You're working right next to the DRG, and like my mama always said, spine surgery would be a lot easier without blood vessels and nerves. So it's imperative that I know exactly where I am, and I'm really careful. And yes, I check my car alarm 3 times before I come in, and use delicate Asian fingers to very carefully remove all that. It's like taking gum out of shag carpet, but the shag carpet is like an antique, and it's priceless, and you can't injure any of the fibers. That's basically what the surgery's like. So wish me luck. Wow, that disc herniation is just wanting to fly out of there. That's the first look. That's one of the reasons why I still use the blue dye. Immediately tells me where I am at, because everything looks white otherwise, or red, and the nerve is white. So yeah, everything's a nerve until proven otherwise. Favorite pituitary. That is such a perfect picture. I don't even know what to do with myself. I am so lucky to have such an awesome team. I'm like a Formula One driver. I'm only as good as my team lets me be. Extension of my finger, you can see me kind of dissecting. Look how much scarring there is. Because all nerves should be completely free and non-adherent, because it slides all over the place as you move your body. And any adhesions is abnormal. And there's a bunch right there, that's clear. I always look for the first anatomic landmark called Wagner's Arch. I just saw Ralph Wagner. He's lost a lot of weight, but he's still massive. It's like a German speed skater. His thighs used to be the size of my torso. It's still almost the size of my torso, but he's getting old just like me, and he's losing some weight. He's looking good though. But his hands are still twice as big as mine. Anyway, Wagner's Arch, it's the pedicle, the posterior vertebral body, and the rise of the supraarticular process / lateral recess. And I'll know when I did a decompression when I can get this thing inside there. See how I cannot get this inside there? It's because, yeah, there's stenosis. So one of the ways I know I'm done is that I can get inside here. Right there, I gotta get all that junk out, right there. I wish you could appreciate how much work I just got done with this laser. It is truly a magical device. But it's not great at controlling bleeding. The trigger flex electrical probe is best for that. So all that wall right there was that tissue that I said needs to go. See how it doesn't work very well on flimsy tissue? That's what the trigger flex probe is good for. And the laser is good for firm, hard tissue. Annulus, disc osteophyte complex, osteophytic bone, the bone spur bone that is a little bit weaker than normal bone. Because you can use the laser to remove some bone too. It's slow, but it's precise. But this is mostly a disc problem. Look at all this junk right here. Okay, so some of the other tricks, you use the actual cannula as a dissection tool. We call it the pimple popping maneuver. There's the exiting nerve root, that little band right there. Look away. You see why we call it the pimple popping maneuver. Regular tuitary now. Sometimes it will squirt right into the mirror. Look at that. Oh, this is going to be a boy. Oh, I have to take the whole scope out. How gratifying is that? You poor thing. Oh, there's a lot more. We're going to pile it up into a big pile for us. You can have like a little disc party. Vertebral body, that's exactly where I am. That means that the nerve is right in here. Right there. But more medial to me. Whoo, I love this thing. See that? It's like my teenage kids, though, it's not going to come out without some struggle in the fight. You can see how annoying it can be with mechanical instruments. You have to move the endoscope a lot more to get to everything. The side-firing laser will reach it without much ado. Can I have the curlicue tuitary? Or you can use the curve grabber. See how it curves up? How cute is that? Look at how fast that was. I don't know why I just didn't use the laser right off the bat. I guess I was trying to get out a massive single piece of disc and start screaming in glory, but today we must do just vaporization and shrinkage. It's not as dramatic as ripping out a big, huge piece of disc like a mouse from a drain. But this is kind of cool. kind of octopus-like. Look at that. Really, it's just using different tools to do different parts of the job. Because like everything in life, certain things are better for certain things, and while others aren't. I love it when the camera is on the undersurface of the working instrument because I can see everything. But it's designed to work on the other side, which is so silly, but that's just me. That's the human condition. Humans hate change. The only reason why it's like this is because that's the way it was always designed. But homie, don't play that. The San Diego Gen 2 system is going to be way more thoughtful and way easier to use. You won't have all these visual impediments of traditional endoscopic surgery. Okay, it always starts to bleed once I do the decompression because now there's no more pressure on the blood vessels. That's my story, I'm sticking to it. And then, like I said, cannot do this surgery without this instrument right here, trigger flex. It's electrical, so you have to be so careful not to shock the nerve because that happens every once in a while. Even though you're not anywhere near it, because sometimes the tissues conduct electricity. I know. No duh. A kid could have told me that, but yes. That's why the laser's so awesome. That's why the drill is so awesome, because sometimes electrical instruments aren't great next to nerves. But again, you absolutely need to have it. So remember that big wall of disc that was right here? All gone. And then right here is the canal. Remember I couldn't get in very easily? It just falls in here. That literally flimsy tissue right there, I'm going to treat some of the undersurface, but leave it so that it acts like a nice little velvety surface for the nerve to slide back and forth, because that's the natural surface. I don't want to remove that unless I absolutely have to. Oh, that feels good. And then looking backwards out the neural foramen, that's the exiting nerve root right there. Look away, look away. It's all red and hot. There's a bunch of stuff right there that I removed right here. South and toward me. Lots of inflammation, but again, all that stuff is debulked. I'm just going to do a little bit of cleanup right there. And 3-4 is done. I feel so good. If you don't wake up feeling better, I will be shocked, I tell you. You want to see what an angry exiting nerve root look like? There it is, right there. It's surrounded by a sheath of really vascular tissue. It's all stuck to itself. We call that, injected. Like your eyes, after you've been up too long. Wow, this is hard. Man, I swear to God, everyone wants to do foraminal decompressions. It's the hardest surgery, because you're working right around the exiting nerve root behind you. An intracanal extruded disc herniation is in front of you, away from the exiting nerve root. You just reach in there and pluck it out. These foraminal disc herniations that seemingly are so easy, to me, they're the most difficult. And it's the bloodiest. Okie dokie, I use the nav dilator and custom dilator to get to where I want to. Put the guide wire down. I'm switching over to the spaghetti noodle dilator. Someday it'll be one piece. Shot and save. That's a kakapupu just too. Shot and save. You can see it outlining the disc herniation. Oh yes, definite caca. How cool is this? So that's what a disc is supposed to look like. That's at the edge. It's white, it's smooth, it's got these collagen fibers, and it's really firm. But the kakapupu is right here. And all right here. Look at that. And there's the edge of the bone that makes up Wagner's arch. I just saw Dr. Wagner in Chicago at the North American Spine Society meeting. I think we already talked about that. And told him I think about him every single day And he says, I think about you too, Choll, but he didn't tell me why. So that's worrisome. And there's Wagner's arch. And I should be able to just pass this instrument through there without any impediment whatsoever. But no, not yet. Not until we get some work done. It wants to let me in, but all this needs to go. Look at all this kakapupu disc. Away with you. These broad-based disc bulges or disc protrusions versus extrusions are so much more difficult to deal with because they hardly ever come out as one big piece. More like my punk teenage kids fighting me every step of the way to get their work done. These little white crystals, that's what an epidural steroid injection looks like after a while. Sometimes there's so much of it, it looks like thick cottage cheese and things are scarred to it. So too many injections does the opposite effect, it causes scarring. Probably because the foreign body load that the body experiences. Oh, magical. I enjoyed this so much better than using the mechanical drill or the rongeurs or reamers. So much more controlled, so much more elegant and sexy, and like they said, it's better to look good than to feel good. Feeling good. I don't know if you can appreciate it, but this is such tedious surgery. You can see why spine surgeons don't love this surgery, because it's annoying. It's like building a ship in a bottle. When I was a kid, I'd be like, who would want to do something so stupid? But some people just like a challenge, I guess. I guess that's the way I am at work, but let's face it, this is not, a ship in a bottle is lame. This is not lame. Final check. Large area of blockage, totally free now. All that stuff, bye-bye. Exiting nerve root, happy. Look at all these little adhesions of the disc herniation. You can see the exiting nerve root right on the other side of that fat. Lots of adhesions, look away. I generally do not like to see the naked exiting nerve root stripped of all its perineural tissues and blood vessels, because I don't think it even likes to be looked at and undressed. But it's inside this fat area right here. It's huge. Doesn't look nearly as unhappy as the level below that I just did, but that makes sense. Looking upside down and backwards, like a long time. Look at how everything's stuck to itself. Fascinating. Anyway, I am thoroughly satisfied with this surgery technically. Now you just need to comply by getting unbelievably better so you can get back to your life again. That's your job, now that my job is over. No, too early. Okay, this is the second go because somebody forgot to hit the record button. The surgery's all done. I did it through three little incisions. I said something really hilarious, like it looks like you had a vampire bite with like a crooked vampire mouth with a huge overbite, but the second time around it's not as funny. But the surgery went beautifully and we're all praying for a speedy recovery, right guys? Yeah.
Woo!